Okay, we ready to get going? Everybody nod their head. Okay, I'm seeing nods, yes. Okay, so our next speaker will be talking about ECT, Electric Convulsive Therapy. Nilly Essaides is a WICL member for about a year and a half now. Can you hear me? She's been a member for a year and a half. Her background is in journalism. She has a master's in journalism from the Columbia School of Journalism, and was a journalist, wrote on financial issues for a number of different papers, magazines, publications, including The Economist, for a number of years, retired about 2 years ago. She describes herself as a researcher. And so this topic is one that she has obviously written a lot about for The Economist and various financial magazines. Laugh, laugh, hint, hint. So anyway, I'm going to turn it over to her and let her talk.
So hi everyone, and thank you for coming to listen to this presentation since it's a very niche topic. Like this. Since it's a very niche topic, and if you were here last term for my presentation on mental health, the history of mental health in women, I was concerned you won't come back. So, but anyway, this presentation we just saw, which was excellent, is really relevant to what I'm going to talk to you about. Not because I'm going to talk about AI, but it applies to the research I did in order to create the presentation. And so I did some things right, and now I learned I did some things wrong, but I think mostly right. I first read a lot of academic papers and books about ECT. I actually went through ECT, so I'm a pretty credible source for that process. And then I started asking a tool which wasn't mentioned, and I mentioned it before, called Perplexity, which is a tool that you got to pay for, so it's not free. But what it does, it gives you the ability to ask very precise questions, and it shows you the sources that it goes through, and you can click through to the source. And so it's not like you're getting real strange answers. And of course, having read a lot about it, you can tell what makes sense and what doesn't make sense. It did not create the presentation. I did that. But it contributed to some of the research. And I have to say, it took me hours and hours because I went down a lot of rabbit holes. Because you can ask questions in different ways. You can give context to the questions. It's a very powerful tool. So that's all I'm going to say about AI, because you just heard a lot about it. ECT remains a very controversial issue. And a lot of the controversy is justified, but some of it is not, and has to do with, no. What am I clicking on?
Just hit the space bar.
Oh, the space bar. Sorry. I don't know how to get out of this one now.
Hit the X at the top.
Oh, I see the X, yeah. Okay. So a lot of it comes from perhaps what you saw ECT looks like. And you probably recognize the face over here. I'm going to play the clip, and then I'll talk to you about it. There's probably an ad before it.
We were wondering, what are you...
Mr. McMurphy? Please follow me. You and me, Chief. You take a cigarette break, boys. Easy. I'll be fine. You? Beat it.
Would you sit up, please?
Sure. Love to.
Boy.
There, might be a little fluid in them boots, you know what I mean, boys? Just a little leak. Light shine, boys, and send the specimen to Nurse Ratchet. You know what I mean? Huh?
Yeah.
All right, out with your gum.
Huh?
Out with your gum.
Okay, this won't hurt, and it'll be over in just a moment.
Uh-huh. What's that?
Conductant.
A little dabble, do you? Right, Mr. Jackson?
Open your mouth.
What's that?
This will keep you from biting your tongue.
Well,
Now just bite down on it. That's right. Just bite down.
Huh?
Now bite down on it.
Good.
Are you ready? Here we go.
Now, one big breath. Very good. Gentlemen, I'd like to begin today. It shouldn't take too long.
How about it, you creeps, you lunatics, mental defectives? Let's hear it for Bull Goose Randall back in action, nice.
So obviously, a lot of you, most of you saw this movie, especially since it was filmed right here in Salem at what is now called the State Hospital. Raise your hand if this is the, raise your hand if this is the only depiction you saw in popular media of what ECT looks like. Okay, most of you. And so that to me is an indication of just how prevalent this image is, and which is brutal and painful to watch, and gives a lot of people the impression that ECT is a horrible thing. So that was, even though the movie came out in 1975 or 1973, right? The depiction that you saw was of ECT in the 50s and 60s. It's not true in 75. That's not what it looked like in 75. At that point, it looked very different. But of course, this one looked more interesting. This is what it looks like now.
ECT has changed all of my moods back to the person I used to be, which is incredible. I actually spent 3 months not coming out of my house. I wouldn't even walk out the door. It got so bad at one point. I tried to kill myself 6 times in the past few years.
How are you today?
Good, how are you, Ava?
So since your last treatment, have you had any problems?
No. Actually, it's been really good.
So it's essentially, it's the fastest working antidepressant and the most effective. an acutely suicidal person who needs urgent, immediate response. And ECT is the gold standard treatment for that type of depression. I'll still see you afterwards.
Yeah, so the only thing I'd ever seen was the things that I had seen in movies. And I, of course, got the, one flew over the cuckoo's nest type reaction to it. And when I first came in, I was pretty nervous. I was terrified. They made it so much easier, and the staff here are so incredibly friendly.
It's a small amount of current. It's nothing like what's in the outlet at home, okay? The level at which just the smallest amount of energy can induce a generalized seizure. So yeah, just take some nice deep breaths in with the oxygen. That's what will get you off to sleep.
I don't remember any of it. I don't feel any of it, so there's no pain involved.
And these are the stimulus electrodes, basically just the way to deliver the energy. The amount of electricity is tiny. So it's ultra safe. She's on a heart monitor, brainwave monitor, oxygen. And this machine tells us when it's safe. It has some safety protocols. The sounds we're hearing are just warning us that the electricity is going to be delivered. That whole sound means the electricity is being delivered. And that's the stimulus. Then we watch to see if her body moves, which is moving a bit. That's not uncomfortable at all for Melody. The seizure's already stopped and we're done. That was it. And that returns her to normal. Isn't that cool?
I'm back to 100% at work. I'm back to 100% at home. And I'm watching everything improve. And it was like one day a light bulb just kind of went off and I found me again. And all of a sudden, the sun seemed brighter, the world was better. Why not take a chance and give yourself the opportunity to have the rest of your life back?
So this looks great, and it was put out by a medical institution, so it's got a bias. And the bias is to make it look great and have more patients ask for the treatment. And one of the things that I've kept in mind throughout this presentation, which came up earlier, is that not to trust certain things. I mean, I know from experience this is what it looks like, but I also know there's more to it than that. So ECT today is administered to about 1 to 2% of psychiatric patients in the US. That's compared to 50% in the 60s. Obviously a very high number. There is a recent movement among some practitioners to make it the first line of treatment for certain diseases, especially depression. And I read about that in ECT Today, even though it's a monthly publication. And it hasn't gained any kind of traction within the scientific community. So modern ECT is a very quick procedure. It doesn't hurt. It takes place in a hospital, and the staff, as you saw, is very friendly. You got to answer some questions. You meet your care team. You get an IV with a very short-acting anesthetic and a very strong-acting muscle relaxer. When it's over, you move to a recovery room as they're moving her. And within 2 hours or so, 2 to 3 hours, outpatients can go home. Now, they can go home not like they came in. They are disoriented, confused, foggy. Obviously, they have to have a driver, but they can go home. In between treatments, you're very foggy. You don't remember anything that happened within those 3 weeks afterwards for a long time. You're also cognitively impaired. And they say for about 3 weeks afterwards, I can tell you it took a lot longer than 3 weeks to actually be in control of my mind. The funny or very telling part is that while I thought it took months, I went back to work after 3 or 4 weeks, and I asked my boss if he felt the difference in terms of the quality of my work, and he said no. So that's kind of a telling story. Now we're going to go back to the history of ECT. When did it come to be? It was in 1938, invented by a neurologist named Ugo Carletti and a psychiatrist named Lucio Bini in Italy. And they had the first human study, and they showed that the result was much better than other treatments available at the time. Now, you gotta know there are no medications at the time. What they were comparing it to was insulin-triggered comas and chemically induced seizures, which often resulted in death. And so it wasn't a very high bar to say that this is incredibly more sophisticated. And because the initial reports were so good, it quickly spread in Europe and the US. The early evidence of effectiveness in the 50s mostly was based on anecdotal evidence, case studies of people who went through it, which would not meet any scientific standard that we have today. There were no control groups, there were no blind groups. It was just a few people telling their story. In the past 20 years, the research has evolved. A lot of the research up until recently was meta-studies of multiple researchers. And this is an area where AI came in faulty, because I've read a lot of medical papers ahead of that, and I knew that a lot of the studies that the meta-studies relied on involved very few patients, did not have any follow-up beyond 3 months, not with regard to efficacy and not with regard to side effects. And so if you take a whole bunch of studies that are not good and you do meta-analysis, your results are not good. As I said, most studies did not measure anything beyond 3 to 6 months, which is one of the biggest issues with ECT today. So what's ECT? Think of it as a defibrillator to your brain. It sends a 30 to 60 second electrical pulse through the brain to induce a seizure. It's done by connecting 1 or 2 electrodes to the side of your head. Recent studies show that 1 electrode produces less damage, less side effects, and equally good results. But when I had it in 2013, and the patient in the movie, there were 2 of them. Nurses, anesthesiologists monitor your heart rate, and a typical course lasts 3 weeks with 12 to 15 seizures. It works, and for decades people didn't know how it works. They just kind of saw that it works and kept on going. But the way it works is that using brain imagery in the last few years, it shows that the current affects several chemicals in the brain, including serotonin, GABA, and noradrenaline. It also increases the brain's ability for neuroplasticity, so the ability to create pathways for the neurons to go down to. Now, there's a lot of seizures that are not induced by ECT, obviously, like epilepsy, brain damage, brain injuries. Those spontaneous seizures are very different from the ECT seizures in terms of length. the ECT, as I said, treatment is 30 to 60 seconds. Spontaneous seizures usually last much longer than that. And after 5 minutes, if there's no intervention, they can last for hours. Blood pressure and all these other vital signs are monitored when you do ECT in a medical context. It usually is done under anesthesia and muscle relaxation. The seizures created by more spontaneous reasons are repeated without recovery. They're often associated with oxygen deprivation, and they occur outside a medical setting. So perplexity allows you to tell the AI tool where to look. And I define the parameters of what I'm willing to accept. And the way I defined them was saying there are medical papers, official statements from reputable institutions, and the tool shows you exactly what it's looking to. And so there are some of the current statements about ECT from the American Psychiatric Association. That is, it's very useful for acute severe mental illness, at least in the short term. The Cleveland Clinic says that common side effects include headache, muscle soreness, upset stomach, and short-term memory difficulties, but in most cases they are non-existent, mild, or disappear after a very short time. One of the problems that I ran into doing my research, both in reading and asking questions of perplexity, is there are very sparse studies of long-term effects. And that's reflected in what some of these authoritative institutions say. The FDA said the long-term safety and effectiveness has not been demonstrated. A mega review this year of cognition and ECT by Rose et al. The evidence of permanent memory and cognition is based on a limited number of studies with small samples and design flaws. And that's kind of what I was mentioning. US Food and Drug Administration, memory problems after ECT are usually worse after the first treatment. Very rarely there have been reports of permanent memory loss. Very rarely is very nice, but it does happen. Now, most of the reports of the effectiveness of ECT come from practitioners who ran studies and ran ECT treatments on patients. And that's very important because there's a difference between what doctors say and what patients say. One thing to emphasize again is that the effectiveness is from early on was something that the medical doctors reported. Very few studies ask patients how they feel after the treatment. And in fact, a study conducted last year, so very recent in 2025, looking at doctors versus patients report, the patient reported that less than half of them said they saw improvements, and the doctor said there was a success rate of at least 60 to 70%. The difference between the groups is how they assess effectiveness. The doctors use things like before and after questionnaires, and the patient based their response on lived experience, on what they perceive to be reality. So let me just show you some of the findings of that study. Only 41% said the mood improved. Only 29% said it improved their quality of life. 49% said quality of life was much worse. And 59%, which is one of the things that worries me the most, say they have not been given adequate information about ECT. So one disparity is between what doctors say and patients say. The other one is a gender disparity. Even today, you see that women are more likely than men to receive ECT treatment. And back when, as my mental health history presentation showed, a lot of women were committed to asylums for social reasons, not healthcare reasons, mostly to silence their voices. And so it's not surprising that women were more likely to be subjected to ECT. That bias continues, although for less nefarious reasons. Women are twice as likely to be diagnosed as depressed compared to men who are diagnosed with substance abuse disorders. Women are more likely to stick to treatments their psychiatrists prescribe, so it's easier to say when the depression is medication resistant because they've actually tried the medication. Women, most importantly, women are more likely to seek help for depression. And so that accounts for why the gender bias still exists today. It's not entirely gone. There are studies that show that psychiatrists are more likely to suggest ECT to women because they're more likely to say yes. Which brings up this issue of what you say when you have your discussion with the psychiatrist and whether you can actually say there's informed consent. So way back then, there was no informed consent. It was just, people were just subjected to it, mostly women. These days, there has to be informed consent unless you're an inpatient in a medical facility where it's critical to your survival. And then it could be done without consent. For the most part, it requires consent, but is consent really consent at that point? Can people in their worst hour give informed consent? Because we know depression impairs a lot of cognitive ability, and so it affects decision-making capabilities very much. So how can you make a decision of something that you want or don't want at the moment? A lot of doctors, and that refers back to that 59%, a lot of doctors typically say it's very safe and effective for the treatment of depression without laying out any studies of long-term effects or other serious side effects, so it looks like a no-brainer. And patients can also feel some pressure from family or the doctor, which they trust, to say yes. My main reason from starting out at the start of this presentation to look at that was a statement I made at that mental health presentation that I believe, and I've believed for a very long time, that the ECT affected not just my ability to recall memories from the past, but also affected my ability to form new memories. The first one is called retrograde amnesia. The second one is called antegrade amnesia. And I really wanted to find out whether there is a connection between ECT and my troubles forming new memories. While patients can suffer from antegrade amnesia during and shortly after the procedure, it usually goes away. There are very few studies, if at all, that tell you that it affects your ability to form memory. In fact, I searched and searched and searched and couldn't find one that confirmed my hypothesis. On the other hand, there are very many studies who showed that psychiatric medicine can have the effect of blocking you from forming new memories, specifically Valium. And I have anxiety disorder, so I do take Valium. A lot of what we saw, especially in the difference between doctors and patients' acceptance or response to whether ECT has worked or not, is based on their perception, of patients' perception of whether it worked or not. They're not using scientific data to make that determination. And so there's a big difference between perception and evidence-based of both immediate and long-term impacts on memory and cognition. But does that really matter to us? Because perception is as much, or if not important, as important or more important than the medical studies show. It's how we feel about ourselves and what we think we are. The consequences are the same and can be lifelong. For example, the sense of being less smart post-ECT affects what people do in terms of conversation, activities, and relationships. It creates a sense of self-doubt and low self-esteem. It prevents people from embarking on what they think would be an intellectually challenging course of action or thinking. I know from my personal experience, towards the end of my career, I avoided writing studies and reports on things that I didn't know very well. Even in my retirement, I avoid knitting projects that are more complex, and I go with beginner projects, even though I've been knitting for over a year. And I also feel that, like in my book club discussions, I ask not as relevant a questions or bring as much to the conversation. This is going to be a shorter presentation than I thought. But so finally, is it worth it, right? The question that I asked at the beginning, and the answer is yes. My family tells me that it pulled me out of deep depression right away, so that's a good thing. Some of the experiential issues I attributed to ECT are not really attributable to ECT. They're more related to chronic use of psychiatric medicine. The only caveat is that there are fewer studies of long-term effects, so until there are more of them, we don't really know for sure. It's really hard to let go of something you believed for a very long time. And more than that, admit it to other people that you told that this was the reason and insisted that it's not worth it. So I feel kind of humbled by the research I did and sort of the personal research that I did to find out whether I was right in making that comment, and the answer is no, I was wrong. So that's all I've got. Anybody has any questions or comments, please feel free. I see some hands raising, so we need the microphone. Thank you.
Hi, Virginia over here.
Hi, Virginia.
Hi. My daughter went through deep brain stimulation, which is an impact on brain functioning for severe depression, and came out of it in pretty good shape. Have you done anything with that, or are you familiar with the differences between that and ECT?
Yes. I haven't done anything with it because fortunately, I haven't fallen into fortunately, I haven't fallen into one more episode of near catatonic depression, so I didn't have to do it. But I've looked at research that showed that ECT is actually more effective than deep brain stimulation, although that is a less disruptive and less side effects way of doing it. So if that works, that's just great.
This is Rosamond. I assume that ECT costs a lot more than a prescription for oral medications. Is there difficulty in getting insurances to cover it?
I didn't. The difficulty I had was finding a hospital that would actually do it. My insurance covered it. I don't know how much it cost, but it covered it. At the time, there was only one place in the state of Oregon that administered ECT, and that was OHSU. After a while, the doctor who was doing it left, and they shut down that capability. I understand they reopened it recently with a new doctor, but it's really hard to find a place where you can actually get it, let alone the cost of it.
Hi, Nilly, this is Sharon.
Hi.
I have a friend who is a nurse practitioner who works in a clinic that uses magnets for treatment of depression. They report that about 80% of the population receives some, maybe a bit, and maybe a total relief from the depression. It would seem to me that there's an element of connection between ECT and the magnets in the sense of disruption of the brain and the process. Are you familiar with it, and do you have any comparison to how it works with the compared?
I'm somewhat familiar with the magnets, and yes, it has some similarities to ECT, but it doesn't involve general seizures, which is the sort of the basis of ECT, that it triggers a general seizure. The rates of success that are currently quoted are 60 to 70% release from suicidal thoughts, from catatonic depression, some forms of schizophrenia. And so the level of success of ECT is much higher, although the disruption is much higher as well. Any other questions? Hi.
Hi, this is Joan. I had a cousin who was diagnosed with catatonic schizophrenia when he was a young man. Well, actually, he was a teenager. And he was given ECT, which had really bad long-term consequences. And do you know whether it would be used nowadays? I mean, this was probably in the mid-70s. Would be used nowadays for a diagnosis of catatonic schizophrenia?
Not as much. So it used to, especially in the 60s when the rates were really high, right? 50% of psychiatric patients received ECT. It was then that the definition of what it works for really expanded to schizophrenia, mania, forms of catatonic depression. So it counted a lot of things. Today, it's only used for deep depression, especially depression with suicidal ideation. And so it's a much narrower base. And so depending on what the diagnosis was would affect what the outcome would be like. So it's less likely to be assigned today to things other than catatonic depression or very deep depression.
Hi. Thank you so much for the presentation. And I read one of the bullet points was that it isn't as widely used in other countries as it is in ours. And I was wondering, do you think there's a cultural or societal reason for that?
So yeah, it was Belgium and the US. that have the highest rate of usage. But when I dug into it this morning, and I didn't have the chance to start messing with my slides because I messed with them so many times, what it looked at was number of patients, not number of patients as a percentage of anything. It looked at number of, well, of anything. It looked at number of patients as a percentage of population rather than patients. So that's a whole different ballgame. We have 100,000 patients. That's a very small percentage of this country's population. It's about 0.003. While in the past, in the 60s, it was 1.7. That's an area where I did not dig deeper into Belgium to see what their data like, but I was going to remove that point because I didn't fully trust it. But it's a good catch.
Hi, this is Brenda. Do you know if anyone's doing any studies to see if an electrical charge in the brain might help break up plaque in early onset Alzheimer's?
That sounds like a very interesting idea, but no, I don't know of any kind of application in Alzheimer's. Anyone else?
Hi, I'm Rudy.
Hi.
And I grew up, well, I became an adult during the Vietnam War, and I have a heck of a collection of stress disorder people that came back. Have you ran into anything that addresses that with this?
You mean like PTSD after? So they started looking at PTSD at the point where medications were already available in the early 70s. And so if you look at the graph, which I had but took out, there is a steady increase to the 60s, and then once the 70s start, there's a real big drop because medication became available and it became the last line of treatment. So I don't know I haven't seen any application for PTSD, and it certainly doesn't show up in the numbers. I think that's it. Oh no, Debbie.
Thank you so much. It was very informative. It made me wonder, related to your thought about other countries, or, you answered that question about other countries theoretically not using it as much. But, of course, in my rather jaded view of medical society in general, do you think there's a monetary incentive for these practices that may overweigh the scientific, sticking with a really true scientific exploration on this subject of depression and its treatments?
I doubt that because today we have just 100,000 people in this entire country who receive ECT treatment. I would expect if there was a monetary incentive, we would see a lot more than 0.003 of the population receiving it. These days, it's mostly medications. I think that's it. Yep.
Okay. Thank you, everybody. Thank you, Nilly.